Thank you, Joe. Hello, everybody, and I would like to continue our TCD lectures with some intraoperative images. And I definitely would like to quote Dr. Lumsden one more time, imaging, imaging, imaging. We do have a fancy hybrid operating room, and probably the TCD equipment is still the cheapest piece in that room. So TCD is what you see in the middle, that yellow box. Sorry, get your, I need your paper, sorry. That yellow box in the middle. But anyway, you see the mouse is...
the middle box, the yellow box
yes.
in the middle. Uh-oh.
Uh-oh.
Nope. There we go.
Yeah, thank you. Maybe. So the yellow box in the middle with the head frame connecting to the head. And
nope.
This is our TCD screen we already learned, but if someone came in late, the red signal represents the middle cerebral artery. The blue signal represents the anterior cerebral artery. It means red coming towards your ultrasound probe, blue going away. And all these signals, basically the ultrasound 2 megahertz signal reflecting on the red blood cells. These are a few, sorry, I was a little bit too fast. So this is a few papers, what should be our practice standard, and this is something that we already have, practice standard for intraoperative monitoring. But I just want to educate about the perfusion. How does a brain is perfused? And this is like, I think, the easiest example. The top is how the normal flow looks like. When you have a low intracranial pressure and your systolic diastolic perfusion pressure nicely flowing a low resistance flow pattern. In a moment, your intracranial pressure increasing or your pressure is too low that your diastolic perfusion pressure is matching your intracranial pressure, you're not perfusing the brain in diastole. So if you're just perfusing in systole, that's the spike, it's just not enough for the brain. The brain really likes to have a flow throughout systole and diastole. And finally, this is a really sad part when you increase intracranial pressure can shut down your circulation. So that's your brain dead situation when your increased ICP is right between the systole and diastolic perfusion pressure. The flow goes back and forth, so it doesn't really progress all the way to the tissue. And I just want to show you an example how does a hypoperfusion looks like. So hyperperfusion means that right now we have a mean arterial pressure of 30. You see the gap in the systole and diastole, and now what we're going to do, sorry, I need to go back. Roger, can you start this movie for me, please? So right now from 30, we're going to increase the pressure to 80. So watch that blue flow gap between those red signal. So this is, we're going from hyperperfusion and we assume this person is brain dead, and it's not brain dead, we're just not perfusing the brain. So suddenly when we start to perfuse the brain and we raise the pressure from 30 to 80 mean arterial pressure, we have a gorgeous flow to the brain. So that's how why we call the TCD almost like a stethoscope to the brain, that you can really see and listen to what is the blood flow we deliver. So that's where the perfusion is really crucial. And I agree with you, emboli is just one story, but this is how the embolization look like on the screen. On the middle of the screen, that huge dip you see, this is a good Valsalva. The Valsalva, by increasing the pressure in your chest, maybe just preventing the venous return. Mm-hmm. That's the best example. If your venous return is not there, heart would love to pump, but there's nothing to pump out. So that is the main maneuver, what you can really control and see how the TCD blood flow changes. So that's actually done with during the PFO test. And this is how the TCD signal can improve by a contrast material. This is like a contrast agent injected in the circulation. So TCD definitely sees the entire hemisphere, not just that focused part. So what we learned from the carotid surgeries, and again, we had data from the 90s, that the TCDY monitoring the cerebral circulation, we can see the poor collaterals, we can see the embolization, but we can also check the vasomotor reactivity and but the most important, how we describe the hypo and hyperperfusion. And as you can see on this paper from Dr. Spencer from 97, the incidence of hypoperfusion and hyperperfusion almost similar.
Wow.
So the similarity is coming that if either you have really the hyperperfusion, but the luxury perfusion marker is the double the velocity is 1.5 times of your baseline. And it's scary. We didn't change too much, but in the end of 90s, we had 93% of the cases had microembolus signal. And that is always predicting stroke and TIAs after these procedures. This is just a few signals that if you prep your line properly and you do not have any air in it, you can see the flow arriving to the brain, and you can see that brightness. Can I have the mouse? Just let's try it again.
Is it on?
Easy.
Yeah,
so
there it goes.
on this left side.
Do you have a pad? Does anybody have something, piece of rubber or something that's a little harder? Try the back side. It just doesn't work. Use my hand.
This may be too romantic, Joe.
Yeah, it
oh
works.
Shit, it works. It's no.
Oh, you switch the screen.
No. So anyway, the idea of that you see the brightness improving, that there's another material arrived in your bloodstream, and this is probably your prep line or contrast agent something. When you have too much air, that also shows up on the right-hand side. That lots of white line, those are you really don't want to see. And the big piece, which is on the lower image, that you see, you do not want that big piece of chunk because almost like it's deleting the signal and it's changing your
right.
flow
So that's
pattern.
so the bottom
is a
signal.
microemboli.
Okay.
I'm
so
sorry.
how do you differentiate? I'm sorry.
Yeah, sorry. So this is the microembolus. When you have like a big piece of chunk and it's immediately changing your blood flow, that you see that your mountain becomes flat. It means that you're not perfusing that vessel. This is immediate occlusion, and with that immediate occlusion, you don't need to wake up the patient. You can tell that this middle cerebral artery or the blood vessel is definitely obstructed, and you need to start your rescue therapy and able to fish out that clot.
So now, how can you differentiate between that and air?
So this is not a question of air or what it is. It has to be a solid piece because it's obstructing the flow. I think it's more about obstructing the flow or not obstructing the flow. And so too much air is not good for the brain. So I remember one of the first case I learned about the cerebral perfusion, and the retrograde cerebral perfusion was utilized when you pump with the malfunctioning pump air into the patients. So if you pump air into the patients, what your only option is reverse your flow and try to pump arterial blood flow through the venous system and flush out the air debris. So that too much air, I don't know if you're planning to kill someone, but you need to inject at least 50 cc of air into the heart to be able to stop the heart. If we are showing you later a video that you were injecting 3 cc of air into your pump, that was embolizing for 2 minutes. But tiny pieces. Oh, I'm going to show you.
Yeah.
I have a pretty video of how the 3 cc emboli, how your connector was played a role. So that connector bubble, what you said is like, there's tiny, less than 1 cc air bubbles. They were embolizing for minutes and minutes and minutes. But they did not affect the flow. And I think that's what's important to differentiate when we are talking about the microembolus versus a macroemboli or something which is obstructing your flow and definitely is harmful for the circulation.
But I'm going to tell you too, I have taught you very well, because you said, if your pump malfunctions and you've pumped a lot of air to the patient, that was very good. It's never the perfusionist's fault.
No, never.
Okay.
I'm going to skip the carotid because I think we are not interested in the carotid surgery. This is just one picture that during the carotid, we using a shunt to bypass the surgical field if you don't have perfusion. And this is the same thing. If your cannula or the shunt is not perfusing, you can see there's no flow in the brain. And this is just a simple clamp action that you put a clamp on, suddenly your flow is definitely decreasing. And we can immediately see that how the clamp placement and the releasing of the clamp able to help us. So this one is one releasing, sorry guys, let's go back.
Maybe slow down, it might be kind of going
Yeah.
fast. There you go.
So this is a clamp placed in one carotid, but looks like it's a bilateral disease. Both carotid goes down. So I think that's the other important information why we try to monitor both hemisphere. Yes, unilateral change is going to indicate stroke, but bilateral change is going to tell you there's something wrong with your heart. The cardiac output must be decreased. So this is why the bilateral flow decrease, I think, is really crucial information. This is how we monitor bilateral MCAs. But when we're interested in, say, we have a changes in the ACA, we can also monitor the blue signal, the anterior cerebral artery, because the changes of the flow direction in the ACA also triggers that there's a problem with your carotid. And I think for the open aortic surgeries, that's really crucial. And not just the new technology, how we advance with deployment of the stent and how we improving the flow, that's a clear confirmation. So here, why the ACA becomes a good direction, you can see on the bottom signal that suddenly your signal collaterals do not need it anymore, so suddenly your the flow is changes. And this is the hyperperfusion. So when you're releasing your clamp, and remember the delta percentage, we started at 100%, and suddenly it shows you 220%. That's hyperperfusion. That's the hyperperfusion is what's going to give you headache and seizure post-operatively, but you can control it in the operating room by decreasing the pressure, and also hyperventilation. And this is just few video examples that Dr. Lumsden putting the clamp on. Immediately you see the flow changes. Now he's going to release the clamp, and immediately you see the flow changes. So the improvement of the flow is always our clue that indeed we did a good surgery and our flow is improving. Now we're putting a clamp on and you don't see a flow. This is the time to call for a shunt. So we need to place a shunt to able to provide, but when you place a shunt, and this is why the air is always there, sometimes it's impossible to properly de-air. Even the tiny amount of air is really picked up on the TCD, and then finally when you release the clamp, you see the flow improvement.
And again, and we accept that. I mean, at the end of the day, we accept that. We are, in that particular procedure, many other procedures, we know, even when we do open valves and the left atrium, mitral valve, and the left atrium has, you see it on the TEE, you see the starburst floating around. That is air. And that air is going to eventually make its way through the system. And we just accept it.
But I think we can learn something how to get rid of that air. So we had few approaches. For example, the ultrasound, if you put it on the arch with a high energy, you can destroy those airs. Or you have air maybe coming from your pump and you sensor it, but that sensor maybe with a high pressure ultrasound wave can destroy the air bubbles.
I want to talk more about that.
So those air bubbles, so those air bubbles, if we capture it, we know they're there. I think there's some technology that we can improve to get rid of them. And I just want to compare the open carotid versus a stenting the same way how we comparing your on pump cases. Indeed, when we put a stent in, there's debris going to the brain, but also with the recent improvement of how to protect the brain, we can definitely place a protection device that we are really minimizing the amount of bubbles going to the brain. This example that you're just pulling on a carotid, look at how the flow is changes.
But the blood pressure is not. So if you're not monitoring that, you think you're just fine.
Exactly, and I think this is where these video captures are synced, and these are real time, and I think that's the perfect teaching tool for us. And this is, you are deploying a stent. You're deploying, pulling back between those two black dots. What's the TCD signal? You see nothing. It means if you really put your markers down, hey, I do not, with this really sensitive toy of TCD, which picks up everything, and you're telling me that I can deploy a stent without a single embolus material going to the brain? I'm not a marketing guy, but definitely this is the protection I want in my brain if I need a stenting someday. So these are what we learn, and we can have thousands of cases, but this one video clip is more than 1,000 words in the publication, New England Journal, and I think this is where we need to be open and able to share our experience. And it's like, how can we get to this level? Sure, when you're a beginner, even an open carotid surgery, you have a lot of air, but this is a TCD, a perfect teaching tool for our fellows, that you can de-air, send everything to the ECA, but to protect the ICA. And I think this is where we're learning a lot and able to teach them. So this case is we are deployed a stent and we did not see the improvement of the flow. So proximal, there's something blocking that flow, and we had a tiny dissection, so we had to balloon and put a second stent proximal, and then you're able to see that the flow improvement.
Here, give it a second. Let it catch up. I think sometimes if you keep clicking it,
can you advance it on my?
There it goes.
Yeah, so you see the flow improvement after the balloon, and I think here's your favorite.
My favorite, yes. Thank you so much.
Oh, you're very welcome, sir. So this is an off-pump case, and see the CO2 blower came in and suddenly blow the air into the brain. So for us, this is still stunning, hard to explain that how.
But they didn't know this was happening, right? They didn't know this was happening at the time.
Well, we alerted the surgeon, and I think after that we really went through a bunch of different testing the angle of the CO2 blower, what can we do? And also I really like the idea to fill up the cavity with CO2 to try to get rid of the air that way. So I think we do learn those protections, what's the best technique, and I think where we say we have a perfect, most sensitive tool to really compare devices, or if you just go for the proximal anastomotic devices, I can tell you between the two devices which is better. The one doesn't give you shower of emboli, but able to carve out the buttonhole and able to put your proximal bypass in without the air. So I think this is where we can definitely compare these, and this is my favorite, when you initiating the bypass and when your perfusion is de-air properly and you see that the heart is barely pumping now, but your fluid arrived to the bloodstream, you see the density changes.
So it's not emboli because it's at baseline.
Exactly, and there's no brightness, the density change you see. This is when emboli comes. Oops, sorry. This is an emboli. So when you release your clamp and you see a bunch of emboli, and I think this is where really interesting that while we are doing the perfusion, we have a perfect way of really sizing the emboli. So this is where you are talking about sizing emboli. You do have a non-pulsatile waveform while you are on pump. So while you are on pump, you can see the different sizing material.
Good luck.
So thank you for your luck. So let's look at the left button image. When you see the letter A, that's a high speed, probably small embolic material.
So the bottom line, the upper left corner, bottom line
is
towards
a big
the left
piece
is an A.
because it's but when you see something closer to the baseline, this is a slower moving, has to be a bigger piece.
Okay.
Something is higher up in your waveform, probably a small piece because it's traveling with a higher speed. So based on the speed, I'm trying to differentiate them, but definitely what I'm really scared of is the left upper corner. See the left upper corner materials? They are deleting your embolus signal. They are deleting also your blood flow signals.
Yep, I see the gap.
These are huge gaps. These are huge chunk pieces that we are lucky that we still have a flow after them. So this is where we definitely need to pay attention, all those tiny details, not just the big shower of emboli, but this is a good example. So you see the speed higher up closer to the green line. That's a lighter material. The third A It's sitting on the middle of the blood flow, so definitely it's a real bigger piece because it's traveling slower. So I have few of those TEVR examples for you, and I just want to show you one of our experience with retrograde cerebral perfusion because I think we learned a lot from that too. So when you are stopping the pump and you would like to have a retrograde cerebral perfusion, indeed the flow in the middle cerebral artery can be detected in a reverse fashion. So you need to overcome that capillary opening pressure at least like 40 mercury millimeter, and you can increase the retrograde cerebral flow from 500 up to 600, 700 to open up that flow. After that, you can decrease it, and we can detect the flow up to 450. And I think this is you want to prevent edema. TCD can guide your retrograde cerebral perfusion.
So you're not over perfusing, but you perfuse enough to get the capillary opening pressure, get the flow going, and then you can back it off.
Exactly. And because we are in the barbecue business in Texas, I just want to show you, this was Dr. Safi, Dr. Estrada's slide to train me why the hypothermia is not enough. You need some other protection by the blood flow. So look at this barbecue. So if you just do circuitry arrest, 5 dead. If you do hypothermia, 2 barbecue, and you have 3 strokes, while you do additional cerebral protection, you're going to have 4 healthy animal, and you have only 1 stroke. So you're going to be hungry because there's no barbecue out of that group. So I think that's very important, that how from these animal experiences we can really learn how to perfuse the brain even in a retrograde fashion, so we can change the direction in the middle cerebral artery by a proper cannulation. And because we are adults but we like to play, this is our playground in Houston.
Who's that handsome guy there in the middle?
Not the middle. I want to point out the guy on the right. See that guy?
Hey.
Yeah. Do you recognize yourself from the back? The handsome guy in the middle is our NASA head frame that NASA gave us, and we're able to use that as a cerebral perfusion model for the TCD. The TCD is sitting on that head, and while you guys are hooking up your pump, we were perfusing our head model, and we have a TCD signal placed on that on the head. Oops, can you go back 3? One, advance 1.
So these are really,
Don't play, just advance 1 slide.
and these are micro,
So I want you to watch the TCD screen, the upper,
or stop the pump so I can see that it's. So I just want to see.
and listen to our
confirming that we
conversation
stop the
because we
pump.
recorded that by.
There's air.
Good. That's it.
So don't hit that again.
So you are
Put it in the
purposely
wrap.
injecting air to really test it. How
Yeah,
do we
well,
pick it up?
what
And we
happens
also
is this is
played
your-
how to decrease the flow pattern and increase the flow pattern. Be able to change the flow. And again, this is provided by your Livanova perfusion equipment.
Yes.
So this is why it's a non-positive flow pattern. And this is where you try to create some positive flow pattern by just like holding the flow back, and you're hitting your
Yeah, breaks
connectors
up.
because
So
you
you
had
can
some
even
air
count
stuck in your
Does it-
connectors. And I think this is where we really had fun. Can you play this video? We injected non-sphere
Air in.
material size. This is a 250
They're
micron.
coming.
So they went through the circulation, and we were collecting them. And this is we were watching how we embolize, and we were testing also your filter.
And that's
And
through a
it's-
40
Yeah, I'm trying to
micron.
measure how high does it go, the velocity, how
And
fast
then you
does it
see the
clear
sudden
out.
stop. So this is your filter function. Your filtered them out. So they were not recirculating. So I
Now
think that
it's-
was really stunning that we tested. The second one was 100 micron. Can you play this again, please?
I just want you to listen to it.
So the 100 micron really able to see
Coming
it, and
through?
we
Yeah.
able to get through the circulation.
That is.
Not much.
It's a short
Yeah,
injection
you-
and definitely filtered out.
Here's this.
And I think we really kept your guys happy. But I just really want to show you this
Ready?
because I got you on your
Go.
knees
Go.
One.
one time, at least on your knees. So you were injecting, and look at all there. So this was a 3 cc air injection. How we were able to detect the flow in. So you are showing. And stunning how the air was like for 3-4 minutes, and you watching your watch, and then we figured out there's an air pocket somewhere at the connector, and this is why it was non-stop embolizing. So that air pocket, what was sitting in your circulation, was stunning.
Yeah, well, it's in this. It's in the circuit itself, and of course, this was crystalloid that we were using circulating around through this head. But at all of those connector points, that air will hang up, and it'll just continue as we keep hearing this shower little by little by little by little by little until it is gone. And so I think that's you don't see it, you can't see it, but it's there, and this proves it.
Yes. And I think the happy moment was when we injected the 40 micron, it filtered out. So we have that clip too that definitely filters everything out. So going back to the TAVR, this is when a TAVR DWI lesion started to show up in year 2009, 2010. Look at it, 86% of the patient, they had these DWI lesions.
Wow.
So compared to the surgical, which is about 50%, but definitely smaller lesions. And again, in Europe, they were ahead of us. And in Europe, we got this data from Germany, 2010. And they did DWI and also did TCD monitoring. When you did TCD monitoring, compared to the different companies' valve and the different deployment as balloon-assisted versus just self-deployed, and also the TA, that's this transapical approach, you really don't see differences. The total emboli count is there, but it's interesting that the self-deployment is that the implantation alone is the majority of the embolization happens, why the Edwards valve, the sapient, when you positioning the valve, you have the highest number of embolization, and those are showing on the P statistical significance.
Mm-hmm.
I have a few videos for you, and this is the first one. We just do the balloon valvuloplasty, and this is the submandibular monitoring, because you see sometimes the balloon is quite stable, is not moving too much. But here, we're deploying the core valve, and you see lots of embolization, and you can see the wires that we are not the first guys in this heart. So you can see the history, and you can see how the valve now is deployed on those chicken wires. And I think the videos synchronize what you see on the C-arm and what you see in the brain on a TCD is first, and the best example you're going to see now with a fast, rapid pacing. Before we see this rapid pacing?
Yep. Yeah,
Beautiful
you see it on the top
BAV,
left.
you can see.
Mm-hmm.
And again, you need to deflate your balloon before you stop the rapid pacing. And then you're lucky that you stopped the rapid pacing, the heartbeats came back. This is a beautiful, great examples how the BAV, but also you see that the diastolic velocity kind of giving us a clue how good was this BAV, how good is the valve implantation, how good is the end diastolic perfusion is for the brain.
So in that case, you've got good flow.
Exactly.
Because your diastolic pressure is not going to baseline or below.
Exactly.
So good, nice, open valve area.
And right now, watch when the valve is arriving into the aortic valve. See how the diastolic flow just disappeared?
Mm-hmm.
So you're blocking your outflow tract. Sure, you're not going to see diastolic perfusion. You want to deploy it, so you want to help the perfusion in diastole. This is a short period of time. You want a faster deployment for sure, but this is just giving you a clue that how the flow changes while you even have your TAVR in the aortic valve. So this is not that lucky moment, because this is another balloon valvuloplasty you're going to see. And in this moment, you have a balloon going up.
You're 200 or 160 or?
And after the balloon is deflated, you do not see the heart start beating again. So this is what we can see and
Bernard,
experience
stop
what is the
this.
CPR
We need to place
with
the patch.
VTech can do to the brain.
Okay.
So
Well, it's
meantime, here
VFib,
you can
okay.
see on the bottom of the screen the CPR starting, and later I can show how does the
that
flow
wouldn't be a good
changes
idea.
during the
Do you
CPR.
ever measure gradient after
Okay.
valve
And this is
replacement?
how
to the
the
screen,
rapid
Okay,
pacing
we
started, and after the
Both
rapid
sides,
pacing
both
stopped,
Normally, no.
is
you
gone.
do not
There's
have a
a
flow
return
coming
of
back.
one heartbeat.
So
then we
this
go
is
to
the
flat.
VTech period started, and this
what
is
was
where
very important
interestingly
that
the
again,
CPR
you
and
see
the
the
flow
VTech
improvement you see
waveform in
when the
the
heart
middle
starts beat
cerebral artery
again,
after just one heartbeat.
almost like a most
you see
sensitive
that
EKG you
vibration
can
on
see.
the
But
top of
this
the
pulse,
waveform.
what you detect in
And
the
this is
brain
when
is
Dr.
stunning.
Rayner
That this is
made
your
a call.
VTach, you
And I
have
just
flat
want to show you the next waveform
TCD
because I
signal,
think it's really gorgeous
and
when
the
you
first
have
moment the pulse
successfully
comes back,
restoring the flow.
it's stunning
This is
how
when
much
the big
air is
shower
trapped in
happens.
that stopped heart. And
But
here's
again,
here
you
comes
see
your
that
first heartbeat.
both hemisphere gets a flow back and both hemisphere has a
That just
pulsatile
showers
flow.
of
You
air
can tell
bilateral.
this is
And that was
emboli
just
or
air, 'cause of
something
course
went up
this is a
probably, or
TAVR.
it's just that flow comes.
So that air
Fully
had
TAVR.
to have been in the catheter, the deployment catheter, the valve itself. I mean, it had to come from somewhere. It certainly didn't just create itself.
And I hope it's just there, but definitely there's
So
a
we don't
picture.
know.
Definitely
You're
there's a debris.
So you're saying it's air, but it could be it could be particulate.
And this is my stunning how the brain not perfused. So here's your valve sitting, and you don't see that usually mountains and anything. So this is again, you do not have a brain perfusion. When you do not have a brain perfusion, you start CPR. So this is our fellow hand on the left-hand side. Wanted to make sure the hand is in the proper position, and I want you to pay attention how much the CPR flows to the brain. Tiny, tiny spikes, and I think after our young fellow got tired, we got our senior surgeon. Look at the highest peaks. I'm not going to name our senior surgeon, but I think Dr. Reardon will be really happy to see the flow
There it
pattern.
comes.
So we're cannulating the femoral artery now, and you see the perfusion starting, non-pulsatile flow, but we have too much air. So we stopped the pump, and we said, okay, let's check connections, let's de-air, and start our perfusion slower. And why we de-airing? Look at the slow start on the perfusion, how we really minimize the air. So I think that's why the immediate feedback to saying, hey, that was too fast, that was too much air, and try to slow it. I think this is a perfect example how you can direct your blood flow. I think I'm going to skip this one, and because we're running out of time. Let's see this deployment. So this is a Edwards sapien valve. You can see it's the sheet going, and we have the pigtail and the aortic valve, and now we're trying to go across around the arch.
And you can see it pushing. You can see it pushing
Can you
against
fast
that
forward
wall.
a little bit, Roger? And just on the clip, if you can fast forward to see the valve crossing the arch. See, here comes the valve crossing the arch. Okay, slow it down. You see few embolic material goes to the brain right away. So that is your example. That definitely not as your cartoon showed that your valve is staying in the midline. It's bouncing, and again, how you're taking the turn despite that you have a clever bolt to take that turn. This is the embolic material. Was no protection used. Ends up in the brain for sure.
It's a little jackhammer all the way around.
Yes. So this is when, let's see the next one, please. And this is, again, a synchronized video. Can you play it for us, please? And watch the TCD on the left upper corner is the right side, on the bottom is your left side. And here comes the TAVR crossing your arch again. And this is the core valve, a little bit longer. Look at the materials going to the left side. There's not much material going to the right, but you are embolizing and trashing everything to the left hemisphere. So why we are passing in the arch, so we're not even close to the valve, but we had major unilateral embolization. And after this unilateral embolization, I am losing signal. I lost my left MCA signal, and few debris going to that left MCA, but you can compare to the upper screen on the right side, you still have a flow. This is stroke happening in front of your eyes, and I do not need to wake up this patient. So this patient transferred to the neuro intervention, and with 30 minutes later, after the quick deployment of the, can you advance the slide, Roger, please?
Let me see that thing.
Can you go back? Okay, we skipped it. So the answers are there. Definitely, there's a bunch of different embolic deflectioner filters. This one of them is the umbrella, and you showed the other device. And we definitely studying these as not just DWI lesion is less and where are they, but also if they can decrease the embolic load. So you can see in this case that was like 820 with a control group, and we decreased them half, so almost like 340 by using the umbrella, the TCD count. And this is the umbrella deployment from the right arm. So when you deploy the umbrella, and this is the first case was done in Germany with TCD monitoring, and you're able to protect the brain with that
this is what we expected
filter.
to see.
And now we are deploying
No
a
sharp, for sure.
valve
Pull
with
back the
that
balloon,
umbrella protection,
Watch the device
and
up
definitely you see less embolic material.
Uli, what size
And I
balloon
think
was that?
that's the
It was
clean
a
way of to be able to
22,
really
22.
study different cerebral protection to really show it in the most sensitive way of that the TCD do not
notice
show
he
you
did the valvuloplasty
embolization
in the
while you're protecting the
AP
brain.
view.
So I'm just looking for my last slide. I want to skip these. We saw enough examples. With Dr. Lumsden, we try to bring TCD in the suburb hospitals. So we try to provide monitoring with this remote proctoring. This is a Storz InTouch device that Dr. Lumsden able to see the TCD remotely, and we able to help. And can you advance, Roger, please? So this is the TCD device in the operating room, and this is the I'm remotely able to control. And this is my remote view that I'm able to see the operating field and also the TCD. And this is my head just behind the surgeon to be able to present from hundreds of kilometers away to remotely able to assist. And again, thank you so much for the invitation, and thank you for providing us some fun. And definitely I had to mute all that fancy noise, but definitely there was lots of fun. This is why the people should come to your conference if you want to learn more.
Well, that was very good. I like that. Thank you very much for that. Okay, so Roger, could you put our number up for calling in? And we'll go to a commercial break. Dr. Matoyer just got here, so we're going to bring him up to the table as well, because I think you can weigh in a little bit on this TCD stuff. I'd like to be able to implement this in your practice. So if you're going to call in, go ahead and call. We're going to go to a quick commercial break, and then when you get back, we'll take some phone calls. I think we have some YouTube chat. And if we have any questions or you want to discuss any of this with Dr. Garami, Dr. Matoyer, or myself, please call in. The phone lines are open. Okay, and don't forget, there's a 20-second delay, so turn your volumes down and be a little bit patient. If you call and the line's busy, just call back. Thank you all very much. Mic is on. Hello?
Hello.
Hey. Oh, we lost the girl, the lady. We got to call her back. Oh, she's on hold? Oh, okay, well, we'll go to you first. Hey, how are you? Who's this?
This is Patrick O'Toole.
Hey, Patrick, what's going on, man?
Good. We're not live right now, are we?
We are live.
Oh, great. Well, I have a question then for Dr. Garami.
Yes.
Okay. So, Dr. Garami, can you see the difference between an air embolism and a particulate embolism with the TCD?
Depending on the mood and depending on the device I'm using, few companies claim that with two different frequency on a TCD, you can differentiate, but in my experience, I think these devices still fail to differentiate. 50% of the time, they are rejecting even thinking about it. So if 50% of the time, you don't want to even differentiate, I think that's a bad move. So we tried 2 and 2.5 megahertz on 2 different frequencies to see the different signature of air versus solid. I think we're not there yet. So we continue our research and trying to find better tools how to differentiate those signatures between solid of air emboli. Right now, my commitment is I'm counting emboli, and the total emboli count, what for me is matter.
Okay, great. I have a follow-up question as well. At some of the hospitals we're using the cerebral oximetry, of course, and it does change what I do behind the pump a little bit, especially if we're doing a circulatory arrest type of case. But if we were to start implementing the TCD on a regular basis, how do you think it would change our practice specifically? What would we do? Would we be flowing less, flowing more?
Yeah, before we go any further, I would like to ask you, what did you observe on a cerebral oximeter when you're cooling your patient?
Well, we definitely see a decrease in the oxygenation of the brain.
No, your cerebral oximeter goes up. So when you're cooling your patient down, sometimes you see unrealistic changes. So not just by decreasing the flow, obviously you're going to see decrease of oxygenation, but when you're cooling your patient down, sometimes you see the increase of your NIRS cerebral oximeter. And I think sometimes my explanation, sure, maybe it's less metabolism. This is why you see a higher counting on the NIRS. But I think if you ask an expert on NIRS, say, oh, my device is best. And I just wish that we have more than one sensor. So when you have just 2 sensors on the forehead, 1 inch depth, 1 inch is not covering majority of my middle cerebral artery territories. Mostly it's covering your frontal lobe and maybe some ACA territories, not even MCA territories. Why my TCD signal is properly placed in the proximal MCA, I'm going to cover 80% of the flow going to the brain. Definitely, we can improve our monitoring to monitor the vertebrobasal system as well. So you cover the posterior circulation, which may be even more sensitive for embolization than the carotid system. But I feel that better coverage is better. So that would be my simple answer, going to deep details, comparing your present tool, monitoring your flow versus a TCD. And I just think our issue is that when you buy a TCD device, the company just want to sell you a box. They don't want to sell the knowledge. And I think we need to continue the education efforts, what Joe does, to really give you the education, not just to buy a box, but to really understand what that box shows you. And again, after a few months, few years experience, you will definitely be comfortable seeing the TCD screens and what you observe. And I think it's a tremendous help how you will direct your pump, how you de-air, and how you provide flow during your cases.
Hold on. Do you see a difference between when you do retrograde cerebral versus antegrade?
Oh, big time. Because this was one of the video I showed that when you do the retrograde cerebral perfusion, you do have a filter function. While you do the antegrade cannulation, there's no filter function. So with antegrade, even bilateral carotid or axillary cannulation, you have bunch of debris going up. So I think I'm a big fan of retrograde cerebral perfusion for the purpose that I can direct the pump after opening up the capillary perfusion pressure, that yes, you can dial down, and maybe even 400 is enough. You don't need to shoot 600 or 700 for retrograde. If I see the flow, but my flow is confirmed, not just like dripping blood into your operating field, but I can really see that it's really reached the brain. So I think on the retrograde cerebral, we can find some collaterals that you assume you're perfusing the brain. No, you can come back from the ECA and it comes back to your venous system. The true confirmation that indeed you see the MCA flow direction change and you detect that flow in the brain, I think that's the true perfusion. So I think that's the difference between doing a cerebral perfusion versus monitoring the cerebral perfusion, make sure it's really there and reach the brain.
Eliminating the gestalt theory. Just kind of, it looks good, there's blood coming out. And
Yes, and I think I remember there was a Austrian gentleman who warned me after we first published that the TCD can detect the flow with the retrograde MC. It's like, well, you're going to balloon all the brain, and this is Dr. Schilling theory that we are causing edema. We don't see that edema if you're clever and you dial down your perfusion after you detect the flow. And I think that's where the cerebral perfusion has to be confirmed. So we shouldn't assume. I learned this favorite word is like, we assume too many things. We shouldn't assume. We just detect it. We will objectively measure it.
Well, I think that's exactly right. We just assume a lot.
right.
You know, you cut the aorta open and we're going retrograde and we see blood coming back. So we assume that's adequate flow because we see blood coming back. But is it really globally perfusing the brain?
Yeah.
And I think that's the issue. I think that's what TCD offers. Okay, Patrick, thank you very much. Can we go to our next caller?
Thank you, Patrick.
Thank you. Thank you.
Hello, you're on the air. Hello?
Oh, my name is
Hey.
Doreen.
Hey, Dorina.
Yes, I have one question. My question is, what are practices the cardiac surgery team can implement to minimize stroke with TAVRs? And because you mentioned cerebral protective devices, and my question is, should this be used for TAVRs, or are studies needed first to support this practice as a best practice?
So let me make sure I got your question right. We had a little bit of a difficult signal. You're asking whether cerebral protection, embolic protection devices should be used on every TAVR and whether it should be used for just standard cardiac surgery. Is that what your question is?
Well, it was mainly for TAVRs.
For the TAVR. So, you know,
Because you said that with TAVRs, there's 100% stroke.
There is. If you were to measure, so there's the new stroke classification is you have type 1, which is that obvious stroke that we talked about. You look at the patient and they're in the bed and you know they had a stroke. And then there's the type 2 stroke, which is the new classification, which is any new lesion on DWI. And these are the subtle changes that you see in patients, and they're both cumulative and ongoing. And sometimes they even get worse over the course of time. And when the cardiologists, when they're studying any new device in a clinical trial, they now have to, I believe this is correct, you correct me if I'm wrong, but they have to consult the patient and advise them the difference between class 1 and class 2 stroke, and that their risk of stroke in the class 2 is essentially 100%. Is that what I'm understanding?
So indeed, there's certain trials demonstrated 100%. Majority of the data I showed today, there was like 86% of the patient had DWI lesions.
Right.
And indeed, if we have an FDA-approved protection, it still sounds like a choice for having a protection or not. And I think what I hear from your question was all of the TAVR should be done with protection. And I think I'm on that side, that if we have an FDA-approved device for that indication, all the TAVR should be done with cerebral protection when we know what our complication. And I think this is where we need to go back with our honesty and saying that with the 100% DWI type 2 stroke, we saw the decline of 10% clinical stroke down to 3%. But I think the clinical strokes are still, 3%. We're going back to our accepted complication rate should be 0. I think we still have room to protect the brain. And at the moment, I do not see the cerebral protection used in every TAVR cases today.
I mean, that's 3 out of 100. That's a lot.
Yep.
That's a lot. And let me throw this at you. So first question or first added question to you is, okay, thank you. We're short. We're running a little over, but I hope you all don't mind. What's going on, dude? Did we finish that? Oh, I think. Well, let me finish up on this thought if I can, and I'll be right there. She was asking whether every patient that's getting TAVR should have embolic protection devices. Should every patient having TAVR, regardless of where they are, have TCD monitoring? That's to you, and then I have a question for you as well.
Today, I would say it's impossible. I think there's so many centers doing TAVR and they focus on TAVR that the TCD is not a potential equipment available for everywhere, but it should be a best monitoring for stroke prevention.
Mm-hmm.
So when we're talking about stroke prevention, when it's really count, we move the patients from general anesthesia to awake patients. So I think that's also changed our method of monitoring. If you do have a awake patient during the TAVR, that's the best neuro monitoring because you can ask the patient, how are you doing? Count backwards, and again, have a direct communication to the patient. You can see the clinical stroke that way.
Mm-hmm.
So I'm on a awake patient, I see the best monitoring is talking to the patients. When you do have general anesthesia, I think TCD it's a must for every case.
Well, I'm not getting TAVR, and if I do, I'm not getting it awake. I can assure you of that. That's not going to happen. I don't want to know what the hell's going on there. So,
or you want TCD on your head, so that's your other choice.
I want something. So let me ask you something. As a surgeon, you go in to talk to a patient.
Mm-hmm.
How are you going to approach saying to them, let's say you were a TAVR advocate, how would you go in and explain to them, look, we want to do this TAVR on you. We don't want to do an open procedure, which I think is still better, but we want to do this TAVR, and you've got an 80% to 100% risk of having new lesions in your brain, which could result in a stroke or cognitive dysfunction or whatever it is. How do you reconcile? How do you do that?
Well, I'll just give the analogy to SAVR, surgical AVR, which when we had embolics available, every aortic valve I did, not every cardiac case, I put an embolics in. I sent off the filters for the first 2 or 3 years, and they always had something. Only 1 or 2 times anything, as big as your fingernail, but that does happen as well. And I would counsel them, and I literally would spend the time with them and say, look, I'm putting a filter in. It may or may not get paid by your insurance. So if you're okay with an extra $300 being charged to you to minimize or decrease the risk of stroke, if you were my mom, I'd do it. Mm-hmm. And so I put it carte blanche into everybody. Mm-hmm. And just because of that experience of always seeing something, microscopic, macroscopic, and knowing that there's always something, whether it's clinical or subclinical, going to the brain. Mm-hmm. And that's without TCD monitoring, that's without cerebral oximetry in a community setting. Again, it just makes sense. You're scraping out a valve and putting one in, and now you're in a TAVR situation where you're not taking the valve out. It's a little less controlled, although it's borne out to be a very safe operation. I would filter everybody. Mm-hmm. I mean, if it's available, I'd filter. And there are a lot more filter devices available for TAVR than there were for open SAVR. Mm-hmm.
Yeah, absolutely. You want to go to our I think we have time for one more call. Roger? They hung up? Oh, do we have any? We have anybody else? No? Okay. So listen, let's transition out of this, I think, with just some music, and we'll take a break, and then we'll put Dr. Matoyer's video on that he can narrate about the mitral valve, simplification of minimally invasive mitral valve. I want to thank everyone for attending this session. I want to thank particularly Dr. Garami for coming all the way up here from the big med center in Houston Methodist Hospital, and giving us a great, I think, overview of TCD and its application. I'd like to see it used more commonplace. I'd like to see us using it and seeing what we're doing. Going back to there's these unknown unknowns, as Don Rumsfeld said, and it'd be really nice to know what we are actually doing and if it would change anything that we are doing, whether it be the tools that we're using, the conduct of the perfusion, pulsatile flow, vacuum assist, non-vacuum assist, whatever it may be. I would just love to know, and I hope that it comes a point in time where TCD becomes a standard of care for any patient who is going to be undergoing a procedure requiring the use of extracorporeal circulation. I think it's extremely important.
I'd want it.
Yeah, I agree.
Thank you very much.
So much.
Thank you, sir. Thank you.